Snoring. Such a beautiful sound, right? Don't you love it? Sometimes I actually wonder, right? Why not at the beginning of my word or a zajal piece? Don't say snore, 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 rather than off, off, off. No? Don't you get the same feeling? No? Okay, let's turn it off. It is annoying, right? Snoring would have to be one of the most annoying noises that you can be exposed to, right? Particularly if you're trying to sleep in the middle of the night and the person next to you is roaring away. Silent thing to snore, indeed, right? But look, while snoring can be considered as a source of noise pollution in general, it can indicate something a lot more sinister to the snorer themselves. And that's obstructive sleep apnea, or OSA. So what is OSA? Well, it's essentially characterized by repeated episodes of upper airway collapse during sleep. So the upper airway is that throat region, we have your tongue, soft palate, all the muscles and tissues around it. They close up during the night as the muscles relax, no more air in, no more air out. So probably the first thing you're going to think, well, yes, I'm not getting any oxygen in, so that's one of the first effects. You're going to have a decrease in the oxygen levels in your blood, which isn't good. But probably even worse than that in the short term, you're going to have a build-up of carbon dioxide which you can't get out. That's actually more poisonous. And the brain doesn't like this. After a certain time, we're going to get to a threshold where is known as a cortical arousal or a brief brain awakening, where the brain wakes up to a shallower level of sleep, unbeknownst to the sufferer, mind you, stimulates the muscles for the airway to open so that breathing can resume. Okay? Now, they do save your life, probably, but they are fragmenting your sleep. More important. Okay, so OSA severity is based on the number of these obstructive events per hour of sleep. So you put things in perspective for you. So 60 events per hour. If I say each event is 10 seconds each, that means I'm spending about 10 minutes per hour with no airflow. Doesn't sound too good. And you can just think that these events can get up to 120, 130 per hour and last more than 90 seconds. I've seen several times before. So, well, what's OSA physically look like? So here's a chap who's come in overnight for a sleep study in a clinic or the hospital. He's connected to sensors from head to toe, measuring brainwave activity, eye movement, breathing, and also breathing effort. You can see these bands. Let's see what happens to him during an apnea. At the moment, he's just breathing normally. I think it's working. Yes. And he's just obstructed there. Let's get the volume up a little bit. So the obstructions happen because you can tell there's a paradoxical movement between the chest and abdomen. Right? He's trying to breathe against his closed airway. You can see they're getting stronger and stronger. Come on, mate, you can breathe, you can breathe. Not working. Airway is closed until eventually he gets to his threshold level. Arousal, snore, 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 breathe, breathe, breathe. I'm going to try and get that CO2 out, bringing back the oxygen. So he'll eventually stabilize and the process will repeat itself again and again. Okay. Let's go through some facts about OSA. Firstly, it's extremely highly prevalent in the general population. 9 to 38% of people have it. 80 to 90% of those with OSA don't actually know they have it, so it's grossly underdiagnosed. And up to 50% of those diagnosed still remain untreated. Heavy stats, but you're probably going to ask yourself, well, why should we care? For what? Well, it is the consequences that this disorder causes. So in the short term, a lot of those with OSA are kind of sleepy during the day. They can't concentrate properly, they can't think properly, they tend to make mistakes, and yes, this leads to car and industrial accidents. But in the long term, the consequences of OSA can become a lot more severe. And there's a whole list of them. So OSA in particular is related to high blood pressure, heart attacks, stroke, diabetes, depression, dementia, Alzheimer's disease, certain cancers, and as you could imagine, overall increased risk of mortality. So we should care about it a little bit, right? But if that's not enough, it's super expensive. So the US predicted that in 2015, OSA cost its economy nearly $150 billion. That's in terms of lost productivity, accidents, and also these comorbid diseases that I spoke about earlier. So heavy on the heart and also on the pocket, right? Okay. So there are treatments, luckily. Okay, the main option is CPAP, or continuous positive airway pressure, where someone wears a mask on their nose or nose and face, which is connected to essentially a sophisticated blower to insert a pressure into their airway to open it up and keep it open throughout the night so you can breathe normally. Relatively simple device and nearly 100% effective. Okay? Keep that in mind. So there are also other options. One of them is mandibular advancement, which is essentially something you wear in your mouth, pulls the lower jaw forward, opens the airway up. Only 50% effective. Let's remember that figure. Hypoglossal nerve stimulation is another one. So this is like a pacemaker type device, gets implanted, innervates the hypoglossal nerve, which stimulates the hypoglossal nerve, which innervates the tongue muscle, which is the major muscle of the airway. Contract, open, great. It only works about 25 to 50% of people. And there are many others, including surgeries where you chop the soft palate, inject something into the tongue, move the hyoid bone around, which we'll talk about a bit later, but highly variable success rates. Now, you're probably now thinking, Jason just told us, CPAP's nearly 100% effective. But what's the issue? You want to answer? What's the issue? What do you think? It's annoying, yeah, it's uncomfortable. Not everyone likes to have pressure blown into their face throughout the night, okay? So, and let's face it, CPAP ain't that sexy, right? And look, you might laugh at that, but I've had many patients tell me that before, so it's an excuse not to wear it. So what are we going to do about it? What's the solution? It's us, hopefully in part anyway, so yay. So, I head up the Sleep and Upper Airway Research Group, otherwise known as SWAG, in the Biomedical Engineering Program at LSFPA. So we're a tightly knit team of individuals coming from a variety of backgrounds, whether it be biomedical engineering, mechanical, electrical engineering, also neuroscience, medicine, and orthodontics. So it's a complex problem requiring a multidisciplinary mindset and skill set. Now, our approach, I think, how we're approaching is on several fronts. So firstly, we want to work out why obstructive sleep apnea occurs. Why does the upper airway collapse? Now, there are several reasons why this occurs, and the majority come down to three things. So it's the factors between anatomy, physiology, and biomechanics. And they differ between different individuals, which is part of the complexity. So we want to find out more about this. The second thing is diagnosis. So we want to simplify the diagnostic process, get more people diagnosed with this disorder, but also we want to work out exactly what's going on from these signals that we require, not just obstructions, what is causing it, which will help us tailor treatments, which brings me to my third front. So we're really into investigating the mechanisms of current therapies that are being used, because we actually don't know how they particularly work and why they don't work in everyone. Okay? Can we predict who they work on based on their mechanisms? It's a big one. Can we enhance their efficacy by doing something else? And of course, we want to develop new treatments as well. So the way we're approaching, I think, is rather well-rounded. So we use animal studies, computational modeling studies, and human studies. So our animal studies are an anesthetized rabbit model, where we perform quite invasive and very highly controlled experiments to get into the bottom of this issue. Okay? And probably the first thing I think about, well, do rabbits have OSA? No, they don't, but they are a great model. So the things that we can do in rabbits, we can't really do in humans. Okay? It's invasive, we do invasive measures. To get to mechanisms, we need those kind of experiments. And secondly, throughout history, rabbits have shown to have results directly translatable to the human circumstance in terms of the upper airway. Anyway, and you might be surprised, the rabbit does have a similar upper airway to us. So complementing our experimental model is our computational modeling. And here we can get really into the biomechanics of the upper airway, conduct simulations we can't normally conduct in a physiological model, get measures that we can't normally get in a physiological model. And they kind of work hand in hand. So they build on each other, they help validate each other and optimize each other. Okay? And lastly, of course, the species we care about are humans in the end. So we do human studies, both acute ones during the day, device development and trying to predict mechanisms and treatment responses, but also detailed overnight sleep studies to get a lot of that data. And data is the word these days, so with that, we can potentially use machine learning type techniques to predict diagnosis or make predictions about treatment at least. So given the time, I'm just going to go through a couple of projects we've been working on very quickly instead of throwing everything at you. Now, one particular aspect we're interested in is this hyoid bone. Very weird looking thing, isn't it, right? This thing sits in your throat just below your tongue. I'm not sure if you even know you had it. So if you walk up from your larynx up to your throat and pinch, you're going to feel something solid there, right? And you can move it around. If you swallow, it's got to go up and come back down. So it is a mobile bone, and it's the only mobile bone in the body without any fixed attachments to the skull. And it has a number of muscles connected to it, right? Now, because of that, it has a primary function in a lot of upper airway functions like speech, chewing, swallowing, and deep breathing. Now, interestingly, this bone sits more caudal or lower in those with OSA. The lower it sits, the more severe the OSA. So, gives an indication that at least has something to do with it either indirectly or directly. So surgeons have gone, okay, let's go reposition this bone to treat sleep apnea. Yeah, but their results are quite variable. And this was really surprising to us, right? It's such a central structure. What's going on? There's something not being done right. I'm not saying it should be 100%, but it shouldn't be 17%. So we've gone and asked ourselves these questions and we've come up with two potential issues. Firstly, surgeons don't take into account the baseline position of the hyoid, which means the natural position where you're just lying down before they do the surgeries. Second, they don't prescribe the surgical repositioning. They just pull it in one direction or the other. There's no angle or magnitude associated with it to get to the optimal position. So we wanted to really investigate these factors. We did it in our animal and computational models. I'll just briefly show you some results from our computational modelling related to upper airway collapsibility, because it is one of those primary metrics. Now, what's collapsibility? Closing of the airway, right? When I breathe in, if the airway closes at low negative pressures, that means I'm very collapsible. The more negative pressure I require to close my airway, the less collapsible I am, the less likely I am to have OSA. You can think of it like that. So here we did move the hyoid bone in different directions, so up, down, forward, in between, in different magnitudes, and look at that collapsibility. So positive is increasing collapsibility, negative is down, and just by looking at this plot, you can see there's different patterns of the lines, right? This direction going down actually increases collapsibility. This one going up decreases a little bit. You've got these three down the bottom here, which are really causing the airway to be less collapsible and less likely to have OSA, and they're magnitude dependent. These are forward-based directions. We also combined this with the baseline position, but I'm not going to show the results, and showed that these surgical repositioning techniques do depend where the hyoid is. Now, these results are quite significant, right? Because they're going to enable us to go to surgeons and say, look, guys, you need to think about where the hyoid is, where you should be putting it to get to an optimal position for this particular person. Do we know what the optimal is yet? No, that needs a bit more research, but we've laid down the foundations for us to look into this. Now, along these lines of the hyoid, because we think it's so important, we thought to look at it in combination with mandibular advancement. So the hyoid has connections to your lower jaw, right? If you recall, I said, remember the figure. How many people get treated with mandibular advancement? What's the percent? 50. Some people are paying attention, which is great. So 50%. Can I improve that by repositioning the bone because it's connected to the mandible? So yes, let's try and do this. So for the first time ever, we used an anesthetized rabbit model to combine these two together. This plot is similar to before. Now I've got mandibular advancement on the X, pulling forward. Each line is for high repositioning levels of 2 and 4. So if I just choose this point, so mandibular advancement 4 millimeters, red line is hard repositioning 4 millimeters, I'm collapsing at minus 3.5 centimeters of water. Mandibular advancement on its own at 4 millimeters, minus 1. So it's improving that outcome significantly. So we've got the proof of concept. Next is we want to go and try this out in the field circumstance. So perhaps someone who's not responding, we can pull up their hyoid or move it forward to get them to respond. Now, we're really on this approach now of combination therapy. So maybe hypoglossal nerve stimulation and the hyoid bone together will work, etc., etc. I'm not going to take too much longer, but I thought just to leave with one thing that's really hot out of the oven. And I haven't spoken about it before, actually. So we've just recently, in collaboration with colleagues in Australia, developed a really novel upper airway imaging probe that can be inserted into the airway using optical coherence tomography, which is just a laser that spins and maps it out. We can measure it at several levels along its length, while at the same time also measuring breathing pressure. This is great because what can we do now is just put this in, and I mean the idea is the patient comes into the clinic, the doctor comes and inserts this probe into their airway, taps under drug-induced sleep or awake, does certain maneuvers, and potentially we could diagnose OSA, but more so where I see it's being used, well look mates, your airway changes this way at this level, and your pressure is like this, a correlation, hypoglossal nerve stimulation for you. Right? So exciting times ahead, I think, for this. This device is coming to us, AUB, and we're collaborating with AUBMC to undertake these studies hopefully later in the year. So look, I guess I hope I've convinced you that OSA is a major health issue and we shouldn't be ignoring it. So if you do see someone falling asleep during the day or snoring at night, do convince them to get checked out. And the way that we're going to tackle and win against this is from several fronts. So we need to really know what's happening with the upper airway in OSA. We really need to diagnose it better and treat it better. And I think us as engineers, we're in a prime position to help with this issue because now we're looking towards device development for diagnosis, device development, treatment, and even methodological development such as with machine learning to process all that data we get and make really good use of it. So perhaps if we continue down this research, we're going to actually get closer to silencing the snore and probably reduce a bit of the divorce rate and potentially the murder rates as well. And thank you.